In this video, we are going to see the clinical aspects of thrombocytopenia. Now, what is thrombocytopenia? If the platelet count is less than 150,000 per microliter in adults, this is true thrombocytopenia. Sometimes there can be false thrombocytopenia. For example, if there is clumping during preparation for the slide, if the platelet clump, that may be a reason to give a picture of thrombocytopenia, but it's not a true reflection of the platelet count. Then you've got distribution effect. A large number of platelets are stored in spleen. In condition in which the spleen enlarges, a large number of platelets may be stored in spleen, giving a false value of a low platelet in the peripheral film. And then dilutional effect. If large amount of fluids or large amount of blood transfusions are made, this is possible that the patient may have spurious thrombocytopenia. So the true thrombocytopenia is after you have excluded these three conditions. Now, what are the causes of thrombocytopenia? It may be primary thrombocytopenia, which is called ITP or idiopathic thrombocytopenic purpura. This has an autoimmune basis. The antibodies are directed against platelets, which destroy these platelets. The patient may have autoantibodies. There may be bleeding. If the platelet count is very low, it may be triggered sometime by infections, and there may be, in some cases, splenomegaly. Otherwise, spleen generally remains normal, but in some patients it may enlarge. Then you've got secondary thrombocytopenia, which has multiple reasons. Their drugs are more common. For example, heparin-induced thrombocytopenia, quinine, sulfonamides, ampicillin, vancomycin, paracetamol, ibuprofen, naproxen, valproic acid, linezolid. Some of these drugs, they produce immune-mediated thrombocytopenia. Some of them can produce a non-immune mediated thrombocytopenia. Then infections. Thrombocytopenia is present in many infections, for example, HIV, HCV, Epstein-Barr virus, parvovirus, mumps, varicella, rubella, dengue, Zika. Patients who've got sepsis, H. pylori infection, leptospirosis, brucellosis, anaplasmosis, malaria, and babesiosis. All these can produce thrombocytopenia. Then hypersplenism, chronic alcohol abuse, deficiency of B12 and folic acid, that can produce thrombocytopenia. Patients who got SLE, rheumatoid arthritis, the HELP syndrome in pregnancy, and preeclampsia, you can have thrombocytopenia. And malignancies like myelodysplastic syndrome, defects like PNH, TTP, HUS, DIC, particularly in patients who got leukemia, lymphoma, and solid tumors. DIC can also be initiated by infection resulting in thrombocytopenia. Then you got aplastic anemia and congenital conditions like von Willebrand type 2 disease, Alport syndrome, Fanconi syndrome, Bernard-Solier syndrome, May-Hagelin anomaly, Wiskott-Aldrich syndrome. They all can produce thrombocytopenia. So thrombocytopenia is caused by many conditions. Now, what are the clinical features of thrombocytopenia? This is an unusual bleeding from skin and mucous membranes. The bleeding can be spontaneous, it can be with minor trauma, or it can be disproportionate to the trauma. Patients who have got platelet counts more than 50,000 generally are asymptomatic, and patients who have a count less than 20,000, they tend to have spontaneous bleeding. The patient may also have history of fever, weight loss, drug use, go for nutritional assessment, and family history also should be taken because these patients may be suffering from secondary thrombocytopenia. Look for the causes of or the features of diseases which can precipitate or cause secondary thrombocytopenia. Physical examination, you examine the skin and other sites of bleeding. You check for the petechiae formation, non-palpable purpura, and ecchymosis. The palpable purpura is seen in vasculitic disorders. You can have a dry purpura or you can have a wet purpura. Dry purpura is on the skin and the wet purpura is on the mucous membranes. Examine for hepatomegaly. It may be lymphoma, CLD, leukemia, similarly splenomegaly in CLD, lymphomas, and leukemias. There may be enlargement of lymph nodes, for example, in infections, autoimmune disorders, lymphoma, and other malignancies. So look for the presence of these organs if there is enlargement or not. Then when you get a patient with thrombocytopenia, confirm it on complete blood count. Complete blood count also gives you an idea what is the hemoglobin, what is the WBC count. So examine the blood smear carefully for the presence of clumps as well. Immature platelet fraction may be important. If it is high, it tells the bone marrow is working and the platelets are being destroyed somewhere in the periphery. So IPF or immature platelet fraction may be helpful. Go for LFTs to see for the presence of liver disease, Look for the markers of inflammation like leukocytosis, antibodies to different viruses or bacteria, microbial proteins, for example. You can do an NS1 in case of dengue or other similar proteins. You can check with the DNA or RNA of the viruses or different organisms to see they are present or not. You can go for H. pylori antibody testing, for example. Then go for ANA screening for PNH, particularly if the patient also present with thrombotic episode. Antiphospholipid antibodies and pH should be screened in patients who've got thrombocytopenia. Look for the presence of pregnancy is an independent cause of mild thrombocytopenia. The severe thrombocytopenia is seen in HELLP syndrome and preeclampsia. Then bone marrow examination. If the bone marrow is working normally, if the megakaryocytes are present and normal, that means they're being destroyed in the periphery. Or if there is evidence, you can look for the presence of invasion of the bone marrow with malignancies. And abdominal ultrasound, chest X-ray, CT scan to look for the secondary causes of thrombocytopenia. When you get a patient with thrombocytopenia, it is usually asymptomatic if the thrombocytopenia is mild and requires only monitoring. HIT, that is heparin-induced thrombocytopenia, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, drug-induced ITP, pregnancy and bleeding with severe thrombocytopenia require urgent attention. You may even require platelet transfusion. The first line treatment for ITP is glucocorticoids and IVIG. Second line treatment is rituximab, immunosuppressive drugs, and splenectomy. Third line option is thrombopoietin receptor agonist, for example, L-trombopag. Patients who got secondary thrombocytopenia, identify, avoid, and treat the underlying cause. That will improve thrombocytopenia. Remove all heparin products, for example, do plasmapheresis if required, steroids and immunosuppression in cases of SLE. And for example, if the patient has thrombocytopenia because of the H. pylori, go for H. pylori eradication treatment. So these are the different treatment options which can be opted for. Primary ITP, it's generally the first line is corticosteroid. But for secondary, it's imperative that you identify the secondary cause, avoid if possible, and treat if possible.